Instability testing of the lumbar spine. How applicable are the results? Instability is believed to be a common problem associated with low back pain. Many treatment approaches are based on stabilization exercise prescription. Yet, what do we know about the assessment methods used so that we can determine the value of this approach? A recent review evaluates the accuracy and reliability of commonly used tests in clinical practice. Prior to looking at this study, we need to take a step back and uncover the many facets of why studying and interpreting the value of the tests we use in practice is so complicated. The first general question, then, is how do I approach determining the value of a test I use in practice? Has the test been tested for reliability? In other words, is it likely that other examiners would get the same test results as me? Has the test been or can it be compared to a gold standard and tested for validity? Are there multiple versions of this test? Are there multiple interpretations of this test? What is the test used for? Diagnosis and/or an approach to treatment? A measure of treatment success? Is the test valuable alone in combination with other related tests, or is it of no value? And specifically for instability, what is the definition of instability? What type of instability am I trying to detect, and what type of instability am I trying to address in a management approach based on the results of this testing? Can I use the test as an outcome measure of success? So let's start with the two general categories of instability, structural and functional. Structural instability implies damaged structures destabilizing the spinal segment. The estimated prevalence of structural lumbar instability reported in the literature ranges from 12% of patients attending physical therapy for nonspecific low back pain to 57% of patients with low back pain who are suspected of having structural lumbar instability. Lumbar flexion extension views in the standing position are the standard for pathological structurally based instability. First described in 1944 by Knudsen, measurement on flexion extension radiographs assessed two indicators, sagittal translation and sagittal angulation. In this drawing, sagittal translation is the distance between D and E in millimeters. The sagittal translation percentage is the length between D and E divided by the length between C and E times 100. Sagittal angulation is the angle between the AB line and the CE line. Criteria for surgical fusion are generally accepted as those patients with severe symptoms and radiographic instability of greater than 4 millimeters translation or 10 degrees of angulation who fail non-surgical treatment. However, flexion extension radiographs have been determined to have high false positive rates and have significant variations in asymptomatic patients. Patient positioning may account for the 10 to 15% variation in observed vertebral displacement. So what about functional instability? The concept of intersegmental instability is based on a model of spinal motion segment range of motion. This intersegmental range of motion is divided into two zones, a neutral zone and an elastic zone. The neutral zone is the initial portion of the range of motion which produces minimal internal resistance. The elastic zone is that portion toward the end range, which meets substantial internal resistance. It's proposed that an increase in the size of the neutral zone increases the amount of laxity and therefore increases demands on the dynamic stabilizing systems. Segmental instability could then be described as a decrease in the ability of the stabilizing system to maintain the spinal neutral zone within physiological limits. Given the three subsystems of stability and their relationship to segmental instability, the passive subsystem is most important for the elastic zone, whereas the active dynamic subsystem made up of the muscular and neural subsystems is most important for the neutral zone stability. In fact, many approaches to neuromuscular training are based on that concept. Dysfunctional trunk muscle activation or sequencing and/or an insufficient neuromotor control in general are believed to be a modifiable factor related to abnormal intersegmental movement and low back pain. Functional instability occurs on an intersegmental basis and is not radiographically evident as structurally based or grossly unstable. In other words, there's no evidence of excessive angular or translational movement. Based on the Punjabi model, this occurs in the neutral zone, whereas flexion extension views evaluate the elastic end range zone only. Recently, in an attempt to assess the impairments of body function in low back pain, instability tests have been recommended in the clinical practice guidelines linked to the International Classification of Functioning, Disability, and Health in the orthopedic section of the American Physical Therapy Association. But what is the evidence for this recommendation? A recent study evaluates that evidence in a literature review of clinical tests for lumbar instability and low back pain, validity and applicability in clinical practice, published in Chiropractic and Manual Therapies in 2015. So let's review the logic for why a clinical test is used in the evaluation of clinical instability. Intersegmental lumbar instability is a functional problem and so must be tested functionally. Patients must improve in severity or frequency or both to indicate a construct validity for using the results of clinical testing as a basis for management. In other words, identifying the patients who need stability training must match with success of that approach as compared to, for example, manipulation for hypomobility. More on that later. So, although most prescriptions for stability exercise are based on the functional concept, we don't know whether clinical testing for structural instability can be used also for this type. The researchers wanted to compare the performance of these tests against the standard of measure for structural instability, flexion extension radiographs. Well, some may argue that radiographs only measure the elastic zone of range of motion, whereas functional instability occurs in the neutral zone. But perhaps there is an overlap in these two concepts, given the same tests seem to be used for both. The researchers searched for studies that evaluated commonly used tests for intersegmental instability: the prone instability test, the passive lumbar extension test, aberrant movement patterns, posterior shear test, prone bridge test, supine bridge test, and active straight leg raise. So obviously we need to describe some of these because they are less familiar. First, aberrant movement patterns are actually a series of tests or observations, including a painful arc in flexion or extension, an instability catch, Gower's sign, and reversal of the normal lumbopelvic rhythm. The prone instability test is performed two ways: one with the legs extended, as is shown here, or with a lower position with the patient kneeling. Pressure on a spinal segment is applied to determine discomfort. The patient is then asked to lift the toes off the ground to determine if muscle contraction eliminates the discomfort. The passive extension test is performed with the patient prone. The examiner lifts the extended legs of the patient to a foot or more off the table. Positives include a patient's complaint of pain in the lumbar region or a sense of heaviness relieved by lowering the legs. The posterior shear test is performed standing. The examiner presses backward on the patient's folded arms while pressing forward on each segment to determine if pain is produced and excess motion is detected. Unfortunately, there are many variables that make comparison difficult if not impossible. For the test performance, some of these are performed with full leg extension, some with bent knees, some stabilizing with a strap, some are side-lying, and some are prone. For patient populations, some patients had known conditions while others had no low back pain, or patients with low back pain referred with a suspicion of lumbar instability. The researchers searched for diagnostic accuracy studies on adult populations with a subacute or chronic low back pain if clinical instability tests were utilized as index tests, and dynamic radiographs were the reference test to diagnose lumbar instability, in other words, flexion extension radiographs. And reliability studies on healthy or low back pain adult populations were reviewed if they focused on the use of clinical tests to diagnose lumbar instability. So let's summarize their findings. The final search included only 6 papers that met inclusion criteria. 2 articles were identified as having high methodological rigor according to the QADAS, or Quality Assessment of Diagnostic Accuracy Studies rating criteria. Diagnostic accuracy was investigated by only 2 authors, Fritz and Kasai. They considered only 4 lumbar instability tests: the passive lumbar extension test, the prone instability test, aberrant movement patterns, and the posterior shear test. Kasai et al. Found that the passive lumbar extension test was the most accurate clinical test with high sensitivity and specificity in a sample of subjects diagnosed with spinal stenosis or lumbar spondylolisthesis or lumbar degenerative scoliosis. Also for accuracy, Fritz et al. Determined that for the prone instability test and posterior shear test, sensitivity and specificity were not good. For aberrant movement patterns, specificity was quite high while sensitivity was quite low. There were some problems due to variability in criteria for positive findings. Hicks et al. And Schneider et al. Rated the prone instability test positive when the pain disappeared in the second part of the test, whereas Fritz et al. Rated it positive when the pain decreased, and with Rabin et al., the pain had to be relieved or abolished. Findings for reliability were that for the passive lumbar extension test, the inter-rater reliability for this test was good. For the prone instability test, values in 5 studies indicated an inter-rater reliability ranging from poor to good. Now to the variations in patient populations. Fritz et al. Had a majority who had a prior history of low back pain, and only 30.6% of them had complained about distal knee symptoms. In the Kasai et al. Study, patients had specific lumbar conditions. Most had intermittent claudication, and 42.6% had neurological leg symptoms. The overview of the results indicate that the posterior shear test showed relatively poor sensitivity and specificity, indicating that the test is less accurate than the PLE test and the PIT test. Instability catch sign, the painful catch sign, and the apprehension sign are 3 of the 5 signs included in the aberrant movement patterns investigated by Fritz et al. However, the relatively low sensitivity and high specificity resulting from the study of Kasai et al. Indicated some caution in the use of these tests to diagnose lumbar instability. Well, what about the practical use of incorporating these and other instability findings to determine whether the patient has hyper or hypomobility, and then using this designation to determine if manipulation or stability exercises are the focus of patient management? Fritz et al. In Archives of Physical Medicine and Rehabilitation in 2005 published Lumbar Spine Segmental Mobility Assessment, an examination of validity for determining intervention strategies in patients with low back pain. They concluded that, quote, those judged to have hypermobility were more likely to benefit from a stabilization exercise program, unquote. Similarly, Hicks et al. In the Archives of Physical Medicine and Rehabilitation in 2005 published preliminary development of a clinical prediction rule for determining which patients with low back pain will respond to a stabilization exercise program. So let's look at that clinical prediction rule. For the predictors of success, there was a straight leg raise greater than 91 degrees, a patient less than 40 years old, aberrant motion with forward bending, and a positive prone instability test. And the predictors of non-success were a fear avoidance belief questionnaire score less than 8, aberrant movement was absent, no hypermobility on P to A spring testing, and a negative prone instability test. The likelihood ratios were that for 3 or more predictor variables of success, the positive likelihood ratio was 4. And for 3 or more predictors of non-success, the negative likelihood ratio was 0.2. They concluded that it appears that the response to a stabilization exercise program in patients with low back pain can be predicted from variables collected from the clinical exam. One study not mentioned in the previous reviews was Lumbar Segmental Instability, a criterion-related validity study of manual therapy assessment, published in BMC Musculoskeletal Disorders in 2005. In the Abbott et al. Study, 138 consecutive patients with recurrent or chronic low back pain were recruited. Comparisons to passive accessory intervertebral motion tests and passive physiological intervertebral motion tests with dynamic radiographs were performed to determine any relationship. Here we see the passive accessory intervertebral motion tests, which involve a P to A pressure at each segment by the examiner determining hyper or hypomobility. And here we see passive physiological intervertebral motion testing, which involves a side-lying evaluation, evaluating motion between spinous processes while moving the upper leg in a flexion posture or into an extension posture. For the results, well, only translational lumbar instability was found to be significantly associated with recurrent low back pain. Passive accessory intervertebral motion tests were specific for the diagnosis of translation lumbar instability, but showed poor sensitivity. A positive test results in a likelihood ratio of 2.52. Flexion passive physiological intervertebral motion tests were highly specific for the diagnosis of translational lumbar instability, but showed very poor sensitivity. Extension PPIVMs perform better than flexion PPIVMs with slightly higher sensitivity, a likelihood ratio for a positive test of 7.1 for translational lumbar instability. But look at that confidence interval, 6 to 38%. This is probably reflective of a small sample size. So what about history findings in instability? Well, only one study evaluated the sensitivity and specificity of the history in determining instability. Kasai et al. Interviewed 368 patients with degenerative disease. 88 patients had structural lumbar instability identified by imaging with translation greater than or equal to 5 millimeters. The results showed that pain on standing up and rolling over had the highest sensitivity of 58 and 55% respectively, and a specificity of 88% and 93% respectively. A report that the morning was the most painful time of day had a sensitivity of 74% and a specificity of 80%. Symptoms exacerbated by worsening weather had a sensitivity of 65% and a specificity of 94%. Studies have been performed to determine clinical instability testing's ability to detect measurable instability on flexion extension radiographs, but we don't know their value, nor can we directly measure their value with functional instability because there may be no obvious radiographic detection of instability, particularly because this may be a dynamic mid-range effect not captured on radiographs. So how can I use this information? Well, many of the systematic reviews agree that the passive lumbar extension test is the most valuable, although based on one quality study. Aberrant movement patterns as single tests are not of value, but when clustered together and matched to other indicators, a clinical prediction rule seems to have value in identifying those patients who might benefit from stabilization exercise. Although there are many tests for instability, only a few have been studied. Testing for hypermobility and hypomobility through a passive prone approach or a motion palpation side-lying approach may have some value in determining intersegmental instability. The tests have a good but not excellent ability to determine translational instability when compared to flexion extension radiographs. Clearly, more research needs to be done.